En la siguiente ponencia vamos a escuchar al doctor Stephen Wolf, que es neuropediatra y profesor de la Universidad de Medicina de Nueva York, de la Facultad de Medicina de Nueva York, y director del Hospital de Boston en Nueva York. Esto es una cosa curiosa, es como tener un hospital de Barcelona en Madrid, pero es un estupendo hospital dedicado, es el director del Departamento de Epilepsia del Boston Children's Health Physicians of New York and Connecticut, y del hospital se llama María Fareri Children's Hospital. También escucharemos al doctor Antonio Gil-Nagel Rein, bien conocido por todos nosotros aquí en España, director del Programa de Epilepsia del Hospital Ruber Internacional de Madrid, y a la doctora Patricia McGoldrick, es enfermera especializada en neuropediatría y también profesora de la Escuela de Medicina de la Universidad de Nueva York, y asimismo también pertenece al Departamento de Epilepsia del Children's Health Physician, New York and Connecticut. So we are very pleased to have you here, and we're willing to listen to you.
Thank you, first of all, very much to the Foundation for bringing us here, and thank you also to Jazz for their support of this symposium. We're going to talk together about epilepsy in general and then about the comorbidities of epilepsy.
We're just going to briefly give a review of some of the things about epilepsy and what the International League of Epilepsy is, and just talk about some types of seizures that we see, and then the problems that those seizures have, and then briefly about medication, but also more about the problems that go along the comorbidities. So just to remind you what epilepsy is, it's someone who's had 2 or more seizures without some provoking factor, such as fever, head trauma, or illness, and sometimes they will have recurrent seizures over time, and sometimes they fall into what's called an epilepsy syndrome, which we're going to describe and explain a little bit more. But a seizure itself is a short burst of abnormal electrical activity that causes a burst of electricity in the brain that causes your body to shake, stare, zone, fall, which we're going to show some more of.
All right, so within the category of seizures, so if you go back to the beginning, which is what is a seizure? And again, we said it's a burst of electricity. They can come from one area of your brain, or it can come from your whole brain all at once, or we cannot tell where it's coming from. So if the International League Against Epilepsy classifies epilepsy depending on where what the seizure looks like, where it starts, and then breaks it down into syndromes, and then epilepsy that occurs for a certain reason or a different etiology. And we're going to repeat this again later. So the etiology or the cause of seizures and epilepsy can be structural, can be genetic, it can be infectious, metabolic, an autoimmune process, or unknown. And then we're going to talk a lot about the comorbidities, the other things that occur with epilepsy. So it's not just the seizures or the epilepsy alone that we treat or that we worry about, it's the comorbidities.
So half the problem is knowing what type of seizure they have, then understanding why they have it, and then all the problems that go with it, just as Patty said. So as Sherry mentioned, the seizures can come from one spot, or the whole, which is focal seizures, or it could be generalized, so the whole brain turns on at once, or we don't know. We have a term, we say idiopathic, which means we're idiots because we don't know why or where it's coming from. This is just to clarify again more. We tried to, because we're not speaking in Spanish, just to give you the text so you can see generalized, focal, and unknown.
So a syndrome is diagnosed when there are different types of features. So there's the type of seizure, what the EEG looks like, the electroencephalogram, and differences among the imaging, the MRI. So these can occur together, and they can occur at certain ages. So there are certain syndromes that start in infancy, there are certain syndromes that begin in early childhood, and there are some, for the purposes of this talk, that begin in adolescence. A syndrome can have more than one cause or more than one etiology, but there's no formal classification. So the ILAE has not come up with a classification for epilepsy syndromes so far. Oh, I think I did something wrong. It's okay, I can fix that.
You can't point. She did.
Oh,
Good
look
work.
at that, okay.
Did you do that or they did
I
it?
did that. I was solely responsible for that fix. Where do I go forward?
This button.
Oh, okay, now I know. All right, so this is the prevalence of patients. This is only in the United States, although we do have a slide with the incidence in the whole world. So in the United States, there's about 150,000 new cases annually. So about 1 out of every 26 people has epilepsy, which is about 1% of the total population. And this is the incidence. Remember I said that certain syndromes start in infancy, certain syndromes start in young childhood, and then pretty much there's not a lot of new epilepsy cases until you get into old age. So there's a high prevalence in young children under the age of 10, and then it drops off a little bit into the early 20s. Okay, so people who have seizures and are diagnosed with epilepsy can cause a lot of different problems associated with them. So they have problems with quality of life. Their quality of life is not as good as the general population. And in fact, people with epilepsy have a worse quality of life than people with other chronic diseases, including diabetes and asthma. It can obviously cause stress to the family and the caregivers, and it can decrease the lifespan by up to 10 years. It also, going along with the quality of life, people who have epilepsy are less likely to finish high school, are less likely to have jobs, are less likely to marry or be in a long-term relationship. And about 30% of patients with epilepsy do not respond to treatment, and they have to go on to a second medication or a second means of treatment, which we'll talk about later. Do you want to do that or you want me to?
So, of patients who have continued seizures, as we mentioned, the problems can be the medication, the cognitive problems, or the comorbid problems that go along with the underlying syndrome. There are, of course, educational and vocational issues that we've all been discussing, mood and personality issues from either having seizures or medications, and then all the other things, continued seizures, neurochemical changes, all these things combine to make the journey for this child very difficult.
And so what we try to decide is what's causing the issues, and then there are ways of addressing them.
One of the things that we're very concerned about is that we need to control the seizures as best as possible to decrease the risk of something called SUDEP, which is sudden unexplained death in epilepsy. And this is about, in the United States, it's 1 in 1,000 to 1 in 2,500 children or adults who can have a sudden unexplained death. And typically, it's patients who have generalized seizures, meaning their whole brain turns on at once. They can have frequent seizures, so they're not well controlled, and they have had problems with difficulty breathing in the past. Sometimes we have no idea who this happens to, but our goal is to best control the seizures as possible.
We try to address this at the first visit with the parents because obviously you're terrified if your child has had a seizure. But what we try to say to them is the risk of death is far greater in older people. It's usually men in their 30s or 40s who have some other underlying disability like cerebral palsy or in a wheelchair.
But the point of bringing this up, and the three of us work with many families, is to make the point to the family is not to give up on trying new treatments and new medications. There's always a frustration that I've already tried 5 medications, I've tried surgery, it's failed, and a lot of families get frustrated and give up. But because of this, we try to remind them not to give up.
All right, so
the point of, we talked about seizures that come from one area, seizures that come from the whole brain, but there are some kids that fall into these categories, whether it be genetic or be a constellation of symptoms that come together to put them in a group. And the reason these groups or these syndromes are important is because it might help us to decide on medication or education or some other type of treatment. So we try to put them all together. So the syndrome is a made-up category. They're not necessarily real, but some are based on a genetic syndrome. And as we're getting smarter, we're learning how to split them up into little groups. And I'm going to describe one that's a big group that's just put together, and then one that's a very specific based on a gene. And these have to do with, these syndromes typically have to do with an age of onset, a seizure type, which I'll show you some videos, seizure trigger, the development, the comorbidity, the EEG, the imaging of the brain, and the genetics. So again, we're just trying to collate or put together patients to help decide treatments.
And the use of assigning someone to a syndrome is that if we have enough patients that meet that category, it helps us to decide which treatment option is the best for them. So that's why we're trying to do more and more genetics on patients now. So these are the different syndromes. So they're divided into the age of onset. So the neonatal period is less than 44 weeks of gestational age. So that's newborns. So it's seizures that start in utero while you're pregnant or within 4 weeks of birth, a full-term birth. So if you're premature, you have to adjust for that. Then there are the ones that start in infancy, that's under a year of age. Childhood is loosely defined as 1 to 12 years old. Adolescence is 12 to 18, and then we say that anyone older than that is really an adult, although those of you who are parents of 20-year-olds probably don't really believe that that's true. But no, wait, I pushed the wrong button again.
So the point of the syndrome is sometimes the EEG helps us to pick out what the syndrome is. And we're not going to go into EEG today, but just to give you an idea, it is a useful test.
The thing, though, is that you can have a normal EEG and still have seizures. So a lot of times you don't want to just dismiss somebody and say they don't have epilepsy or they don't have seizures because the 2-hour EEG comes back normally. So it's important to keep an open mind. And there can be abnormalities that are common in the general population. It may help assess for medications.
And it's important to have an EEG when they're having a seizure, because that gives the three of us information about what exactly type of seizure they have.
It's also important to have an overnight EEG and not just a short one.
But the frustrating thing is that there are many barriers to getting a patient to the right treatment, such as a parent not recognizing that there's a seizure, the pediatrician not understanding what that was a seizure, and then just lack of availability of testing, and as well as scheduling delays, COVID, you name it, there are a lot of barriers.
We've had a lot of trouble getting people in for evaluations because of COVID, because people don't have office hours available, and then once COVID finished, there was such a backlog of patients that it was hard to get them in. We also have a bunch of children who have been worked up in school for attentional issues, and they actually turn out to have seizures.
So the real goal going forward is, when we're evaluating for seizures, is to look at what the seizures are, think about the plan, but really to really look at the child in all different aspects, such as the EEG, the genetics, and the imaging. So what we know is that of children and adults with seizures, there is a percentage of them that will continue, despite no matter what you do, they will continue to have seizures. So the current evaluation of how we evaluate them, as I said, is they come in, they get an EEG, an MRI, and genetics. That's our new wish list. We're wishing for that in every country. And then we try a medication. And those of you who are parents know, how do we decide? We try to use what clues we have to figure out what is the right medicine. And once that medicine doesn't work, we try another medicine. And then we try another medicine. But at some point, we have to stop and step back and reevaluate and look at them again. And did that work? And if that doesn't work, then we bring in other tests. We talk about surgery. We talk about genetics. We talk about neuromodulation. So there's a long pathway of trying to find an answer, a cure.
So right now, the thing that we start with when we treat epilepsy, and we start treating when you've had one seizure and an abnormal EEG, or one seizure with a big risk of having another one, or 2 seizures. So the first treatment option is an anti-seizure medication or an anti-epileptic drug. That only works in about 60 to 70% of people. And the rest of them may need more than one medication. We try not to do more than 3 although sometimes we'll have patients who come to us who are on 4 or 5 different medications, and then we evaluate for surgery or dietary therapy.
So these are some of the medicines that we currently use, and they work on different areas of the brain to try to prevent the neurons from bursting and being too much electricity. And they work either on the end of the nerve, where they go to the next nerve, or they work on the beginning of the nerve, trying to quiet down the excitability. I lost my English. The excitability of the neuron. And each medicine works on a different area, but each medicine, when it works on a different area, can cause a side effect in that same area. So that's the problem. You need to know how the medicines work and what they affect. And of course, we're always looking for new medicines that work better than the old medicines.
Or who work on different mechanisms. So this slide talks about patients who have seizures. So it's a low percentage. It's only about 47% that become seizure-free with the first medication. Then you add a second one, that the risk of becoming seizure-free on the second medication drops to 13%. And then when you get to the third and fourth and fifth medication, there's even less chance that it will work. So that's why we try to evaluate early on for surgery or for other therapies.
Just keep going.
Yeah, we'll just go forward.
Keep going.
We're going to go past that one. This is genetic. We're going to cover this. There's another talk after this, so we're going to cover some of this again. But now we're going to talk about the different syndromes that we alluded to earlier. The first one is Dravet syndrome. So Dravet syndrome is a genetic abnormality. It usually starts in infancy within the first year of life. And these are typically developing children who end up having seizures with fever, but they have long seizures with fever, 20 minutes, 30 minutes, 40 minutes. And then they start, after they've started having seizures, they start regressing. So they lose milestones. They're not doing as well as they should be. About 80% of them have an SCN1A mutation, and that is diagnostic of Dravet syndrome.
But what was impressive about Dravet syndrome is it was the first genetic disorder that we as neurologists were able to check the gene, and it would change our treatment, because we knew that Dravet's got worsened by a certain type of medication, medicines that worked on the sodium channel. And so forever we didn't have genetic testing, or we never thought genetic testing was of value because it didn't change our management. But this was the first gene that if we diagnosed it, it could possibly save 3 years, 5 years, 10 years worth of wrong treatments for children. And we've seen that in our own patients. We finally got the gene testing. It's like, oh my goodness, I wasted 5 years trying drugs that were going to make this child's seizures worse. So Dravet syndrome was a real wake-up to all of us neurologists of how important genetic testing is early to help guide us through the world. And so that's why this syndrome is important. And we're going to talk about a medication that has now approved for this syndrome, because we know it doesn't worsen, and in fact it helps this small group of patients.
So Dravet's is a syndrome that has a cause or an etiology, and the cause is this genetic abnormality. The next syndrome is Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome has a bunch of different causes. It often develops after infantile spasms, and it's diagnosed about ages 3 to 5. So the hallmarks of Lennox-Gastaut are they have a bunch of different types of seizures. So they can have atonic seizures, which are drops. They can have generalized tonic-clonic, which are the usual shaking that you think of as a seizure. They can have atypical absence, which are prolonged staring spells, and they can have these little brief myoclonic jerks. They have a developmental delay. It can be anywhere from a mild developmental delay to a more severe one. It can occur with structural brain abnormalities, so hypoxic ischemic encephalopathy, which is the lack of oxygen to the brain, or it can be with tuberous sclerosis complex, which we're going to talk about in a minute. And they have an EEG pattern. So their EEG pattern is this slow spike and wave, which those of you who don't read EEGs are probably not going to, but we're going to have my
Spiky.
pointer here is going to point to the feature.
Anything that is sharp to put your finger on and that hurts, that's a spike.
So it has a slow background, so the background of their EEG is slower than anyone else's in this room, and then it has these bursts of spike and wave intermixed.
But some of our research that we have been doing is trying to teach adult neurologists that they have these patients in their hands and they're taking care of them. Once we were giving a lecture about this and we had adult neurologists in the room and I said, how many have patients with Lennox-Gastaut syndrome? And no one raised their hands. And I said, that's not possible because our patients grow up and you're taking care of them. And they didn't realize it, so when there were new medicines coming out or new treatments, they weren't using them. So we have been going around the country and we made up a new scale to teach adult neurologists that their patients go from, our patients go from little cognitive impairment to more as they get bigger, and their seizures change as time goes on. So they're really dealing with the same patient, but they don't realize it. They think they've outgrown it. And that's important because of the new treatments and the new medications. They need to know that these kids just grow up and they have different problems and they look different. I'm going to show you some seizures, what they look like, so they can have seizures where they drop, which are very severe and very scary. I think you
That's atonic.
so that's a drop seizure, atonic. Drop, so they can show at any age, and they're very scary, and they scare the parents. And then they can be where they can just be sudden little jerks or myoclonic jerks, and you'll see her briefly jerk, and they can be so fast that you can miss it. Or here, this could be a tonic seizure where they suddenly extend and they can fall over as well. So these children have a potpourri of seizure types, but they all have different causes, different etiologies that make it very frustrating. But they do respond to a lot of the same treatments, and we need to group them so we can tell parents to try these treatments.
All right, then the third syndrome that we're going to talk about is tuberous sclerosis complex, which is another genetic abnormality, but it affects a bunch of different organ systems. So it presents usually in infancy. You can have dermatological skin features. You can have problems with heart, kidneys, eyes, and brain malformations. They often present with infantile spasms. So if there is nothing else that you hear from this lecture today, from 2 days, it is that if you have friends or family who have small babies who have something that looks like it could be reflux or spitting up, and they have, you have to demonstrate because of my arm, something that looks like that, and it goes on and it gets worse, and the child looks uncomfortable, and the child regresses, it's very important to get them to neurology right away, because that can be infantile spasms. And the way that they're treated immediately really counts in helping them to get better. So tuberous sclerosis complex has a big incidence of infantile spasms, which is that type of seizure. It's caused by a mutation in a TSC1 or a TSC2 gene, and it's usually spontaneous. It's a new mutation, which is what happens with most of the genetics, as you heard earlier. So it's not something that's necessarily handed down from the parents.
Now, these three syndromes, our colleague Antonio here, he says these are the toughest for all of us to treat, whether you're in Madrid or in New York. And we sympathize with each other because we go, oi, these are just so hard to treat. So we're always looking for new things, and we're comparing notes on what to try next. And sometimes we get a drug first, and sometimes you guys get a drug first, and we all talk to see what is the best medication or surgery, which Antonio is going to speak about as well. So there is a new class of medication that is now available in Spain, which is the cannabidiols. It's everyone knows of medical marijuana, but this is different. This is in the marijuana cannabidiol world. There are 3 different components of the cannabidioids, and we're very interested in the endocannabidioids. This is what's naturally in our bodies that make us feel certain ways, but there are ones that come from the plants, which is the phytocannabidioids. And,
Well, it's
oh, it goes, okay, so that, we're talking about the plant, and then the endogenous is what we have, and synthetic is what we make chemically. So this class of medication is been really helpful in some of the patients with the epilepsy syndromes that we were discussing. The ones that we're looking at is really the pharmaceutical formulations. There are a lot of folks that are out there making either hemp or medical marijuana, but what we found when families were using it in the United States is we weren't getting the results because the way it was being made or processed was very different and it wasn't very consistent. So we would have families saying, oh, I got a good result here from a brand from Colorado, but a different result from a brand from California. So a family worked with a GW pharmaceutical in the UK and helped to develop the pharmaceutical brand of just cannabidiol, no THC. None of the psychoactive components are in cannabidiol. And we were able to prove that there are no psychoactive components in plain cannabidiol. So again, the most important was to have a company to produce a drug that we knew was pure, we knew didn't have other artifacts in it, because you have to remember that the marijuana plant, the cannabis sativa, it's a weed. So every weed just sucks up what's in the dirt. So if you have nitrates or chemicals or fertilizer or whatever you put into the ground, it is in the plant. So it's very important that when you're making a product that's going to be a pharmaceutical grade, that it doesn't have the chemicals in it that we're putting in your garden. It needs to be natural, which is very important. So Epidiolex, which is now available in Spain to be used with clobazam, is in America our first approved drug that's a cannabidiol. It works differently than all those other pictures that I showed you on the neuron. It works differently, and we actually don't know exactly how it works. We think there are about 5 different mechanisms, but we're not really very sure. But we know the 3 syndromes that we just talked about, Dravet, Lennox-Gastaut, and tuberous sclerosis, we've had significant improvement in seizure control. Maybe some people without seizures, some people still with seizures, but we definitely have seen improvement. And having a brand that's made by a pharmaceutical company that's consistent every dose has made a huge difference. Just to mention for any of you who are interested in side effects, there's always side effects of every medication, whether it be natural, not natural, and interactions with the medication. So you have to monitor the liver because we have seen liver side effects on the medication, especially when used with valproate or divalproate. We know that there is excessive sleepiness with clobazam, so you need to speak to your healthcare provider about adjusting the medication. You just keep going. And we talked about sleepiness. And again, when changing medications, you need to be careful when changing medications. So the point that we just want to make is that it's worthwhile doing genetic testing. It's worthwhile trying to characterize and put people into categories. And it's worthwhile, just keep trying different things. And I think so let's just go to the other part of the talk. If they could cue up talk number 2, Spain 2, please. I think you can click out of that.
How do I click out of that? This? Yes.
Yeah.
That's what I did wrong before. So we're going to talk now about the comorbidities of epilepsy, because sometimes what's the bigger issue is not the seizures are horrible, but the bigger problem for the family is often the other things that occur. It's the learning disabilities that we talked about today. It's the psychiatric comorbidities like depression and anxiety. And we'll talk about that a little bit, but we're waiting for them to load the other talk. So I think I completely confused the poor man who is managing this.
How do we get to the other talk?
You have to click out of that here, X.
He has to do it.
Go to Spain.
No.
That's not it. Back.
One back.
Go back to the one that says Spain. That one. Okay, and some of this may be the same information that we just talked about. But what we're trying to do overall is to talk about how to manage pediatric epilepsy and how we can use precision medicine for different, go back.
Go back.
Yeah.
Sorry.
Okay, so we talked about this already. So the comorbidities, so the bottom paragraph is the most important. About 25 to 50% of the patients who are diagnosed with epilepsy have comorbidities that include psychiatric diagnoses, problems thinking, mood issues, anxiety, attentional problems, and also migraines. The prevalence, and I talked about this a little bit with the incidence, so it's anywhere from 3 to 5 per thousand in developed countries. It's a little bit higher in underdeveloped countries. It's higher in rural areas than it is in cities, and there are more focal seizures or localization related, which is we talked about the seizure arising from one area of the brain. And only about a third of the children can be assigned to a specific epilepsy syndrome. This is again the causes which we talked about earlier. And these are the common genes. So there was that diagram that had the little neurons in the synapses. So this is just another way of presenting that. So the ones in blue are the channelopathies. So these are problems with the flow of electrolytes in and out of the cell membrane. So remember cell membranes from biology? So you have calcium and sodium and potassium that go back and forth. And what you try to do with the medications is to regulate the flow in and out. So that's a genetic cause. Then there are genetic causes that are problems with the synapses, so that's the space between the neurons. Then there's transcription, which is an abnormality in the gene. And then there is the mTOR pathway. So that's the cause of tuberous sclerosis that we just talked about. But there are a bunch of other abnormalities that are overgrowth syndromes that occur with a problem in the mTOR pathway.
So this is our alphabet soup. So the earlier lecture of next generation sequencing created this alphabet soup of genetic disorders that we've all quickly had to learn. But now that we know what they cause in the brain, we're able to better tailor the medicine to the patient. So this has really rapidly changed in the past 5 years.
All right, and again, why do we treat so that people do not die of seizures, to prevent injury and to prevent problems with cognition? And how we talked about this. And how do we decide? So this is important. How do we decide on a medication? So the goal of any treatment is to stop seizures. But we also want to look at the patient and look at their sex and their age and where they're living and decide, and their other comorbidities, and decide which would be the best option for treatment and wouldn't cause more problems. Do you want to do that, or you want me to?
Keep on.
Okay, so there are different courses, so there can be outcomes where they get better and we take them off medication in anywhere from 2 to 5 years. There are ones that are refractory, so they're stable over time, but they have seizures every so often. There are ones that are progressive, where they just get worse and worse. There are ones that improve, and there are ones that it's called remitting and relapsing, and we use this term in multiple sclerosis as well. So they get better, they get worse, they get better, they get worse.
And you don't know which child this is going to be. You don't know if your child's going to fall into any of these categories.
And this is, again, the SUDEP, the risk of death.
And we know that patients with Dravet syndrome have the highest genetic risk of sudden unexplained death, which is very interesting. We don't know why just yet.
All right, now we're going to talk about the comorbidities. So the biggest comorbidities that we're going to talk about today are anxiety and depression, because they are treatable and manageable, but we need to diagnose them sooner than we do. The learning disabilities we've covered with cognitive issues, and then there are attentional issues that are associated with epilepsy. Problem is that we're not recognizing the comorbidities. This group obviously recognizes them, but I don't know that all the healthcare providers are noticing. Every time you go to a healthcare provider, whoever you're seeing, they should be screening to see if you have any of these coexisting problems. So they should be asking about sleep, they should ask about attention in school, they should ask about learning, and then the parents should be the people who bring it up also and are aware that this can happen. There are two different ways of assessing for anxiety and depression. There's 2 surveys, there are 2 free tools. One is called the NDDIEY. And that's an 11-item, and I have a copy of this up here. It's a self-report, so the child themselves fills out the information at each visit. There's another one that's a neurology quality of life that has 8 items that address depression. And then there's another children's depression inventory that has to be administered by a qualified mental health individual. And the biggest thing with all of these is you're looking for problems with suicide for children, teenagers really. These are for ages 12 to 17 who are thinking about suicide. They will not diagnose it, any of these tools, but they will screen for it and they will give you the ability to see how severe it is and how concerned you should be about it. The better tool is an interview. So somebody actually sitting down with the child and asking these questions. The problem is that in most practices, we don't have a person who can do this, but they are used in research studies. So anytime that they're bringing a new medication to the market or a new treatment, a surgical option, this is part of the process. So this is the screening tool, the one NDDIEY, and you'll see the questions, and the child just has to circle the answer. Now, this is validated for people ages 12 to 17. So I handed this the other day to one of our secretaries, and I said, give this tool out to every child who comes in with epilepsy. And the first child who came in was 3 years old. And I said, that child filled that out? And they said, no, the mother filled it out. And I said, well, then it's not valid. The mother can't answer the questions. So you have to be careful how you use the tools. All right, and this is the incidence of the comorbidities. So patients with epilepsy, look at the percentage. So patients with epilepsy, the percentage of depression is up to 50%. If you look at the general population, it's 3 times less. Same thing with psychosis. And if you looked at anxiety, in the general population, 5 to 7% are diagnosed with anxiety, but in the patients with epilepsy, it's 15 to 25%. And it's the same 3 times higher for panic disorders and for attention deficit hyperactivity disorder. All right, so the depression looks different in children and in adolescents than it does in adults. So the things that you need to look for are not being interested in their usual things. So this is a child who may like to play outside with their friends. They don't want to do it anymore. They used to like to read. They don't want to read anymore. It's also problems in school, so a child who was getting, middle of the road grades and now is failing. Problems with sleep, problems with eating more, eating less. Children who are crying for no apparent reason. I mean, we all have children who cried for no apparent reason at some time in their childhood, but if it's happening often, if they're agitated or restless, they can't settle down to things that they like. Regression, not wanting to leave the house, not wanting to leave their parents, and these are all escalated during COVID. We know that all the incidents of this in children and adolescents are much worse for the last 2 years, so we have to be very aware in epilepsy. And then physical problems, so, tired, sleeping all the time, not wanting to do anything, stomach aches, headaches, and the kids who are older, teenagers who want to sleep all the time, children whose weight is going up and down, they're gaining weight, they're losing weight, and substance abuse. Children, teenagers who are using marijuana, who are using other drugs, who are drinking alcohol. The younger kids, it's more that they're irritable and explosive. Okay, so now back to the suicide question. So up to 20% of children with epilepsy report suicidal thoughts. And the best way to ask this question is to say, do you ever think about hurting yourself or killing yourself? And I never believed that this was true and that a child would ever answer this and say, yes, I want to hurt myself or kill myself, until when you ask the question, the next question, if they say yes, is, do you have a plan about how to do it? And I remember years ago, I asked this of a little boy, and there was a large bridge across the Hudson River, and I said to him, do you ever want to hurt yourself or kill yourself? And he said, yes. And I said, well, how do you plan to do that? And he said, I'm going to open the door while we drive across the bridge, and I'm going to jump out of the car. He went immediately to the emergency room. But that's the kind of, they do answer yes. It's amazing. In the majority of the kids who have suicidal thoughts, it's passive. So they think things like, I'd be better off dead, nobody would care if I died. But 4 to 11% have an active plan. So that's the little boy who's going to jump out the door. I forget, another one told me that he was going to use a knife and kill himself, and then you have to assess whether that's actually possible. Is there a gun in the house? Is there a knife in the house? And that's when you start getting worried about it and sending them off to be evaluated.
In America, we have a lot of guns.
We have a lot of guns, yeah. Not us, but a lot of people have guns. Am I still?
Yeah, keep going.
Okay, so some of the anti-seizure meds, so these used to be called anti-epileptic drugs. They have side effects that can look the same as depression or anxiety. So if there's a family history of depression, you need to weed out whether this is a side effect of medication or actually this is a comorbidity that you need to address. And maybe it is a medication that the side effect is making the process worse. And you have to talk to the children separately than the parents, which sometimes is not easy because some of the parents don't want to leave the child. Some of the children don't want to talk. So you do the best you can.
One of the things we're teaching our young doctors is they always just focus on the seizures. How many seizures did you have? How is the medication working? But they forget to ask about the mood. And so it's very important that they ask, you know, has the personality changed? Does the child look more depressed? Does the child look more hyperactive? And we're really trying, and also to ask about sleep. So sleep and mood are the two most important questions besides how many seizures when anybody's on medication.
All right, so then treatments. So it's important to get them into treatment. First-line treatment is medications. There are plenty of medications that can be used without worsening seizures. There's something called cognitive behavioral therapy, which allows the child to self-regulate and manage themselves, so it's sort of a long-term program. For the kids who have really more severe symptoms, it's medication and cognitive behavioral therapy at the same time. And they don't need to go to psychiatry. We also have a large shortage of child psychiatrists in the United States, and I'm sure all over the world. If you have trouble getting into them, there's much more call for them. So the other people that can provide this, at least in the United States, are child psychologists, school psychologists, counselors, social workers, and then, of course, child psychiatrists. So you don't have to wait till they get into child psychiatry. We can also, as neurologists, treat it ourselves and start them on a medication until they get in to see somebody. And the SSRIs, so the selective serotonin reuptake inhibitors, are the ones that are most commonly used to treat, so sertraline and fluoxetine. Bupropion is used for depression. It's also used to stop smoking. You should not use that in kids with seizures. And then I already talked about the moderate severe. The ones who are most at risk are those who have really abnormal EEGs, ones who are regressing in academics, who have abnormal MRIs, the ones who have a history of staring spells of absence seizures. So that's what I just said. For a year, we have a couple of kids who come in and the parents say, well, the school is saying that they're not paying attention. And then we get to see them and it turns out they actually have these staring spells, or the lack of attention is actually a seizure. The ones who are on medication are at higher risk, and the ones who are failing medication, who are on their third or fourth medication, and they're not working, are more at risk. Usually cognition is better if we can get them to a point where they're seizure-free, so we always focus on controlling the seizures and stopping the seizures.
So we do see some children when they have seizures and we stop the seizures that their cognition improves, but then we see some that don't improve or some that actually get worse. So our job is to step back and try to decide, is our treatment causing more of the problem, or is it the underlying disorder or something progressive? And so we continue to have to play detective as these children grow.
And that's part of the reason for repeating tests, for repeating EEGs and MRIs over time if you suspect that something else is going on. It can go through that. If the earlier that they are diagnosed with epilepsy, the more they are at risk for having cognitive or academic issues. And then autism. There is a big comorbidity of autism and epilepsy, and part of the genetic testing is looking at the genes that are responsible for autism and for epilepsy. For kids with autism, there is a risk of seizures starting at a young age, around 2 to 4, and there's another risk when they get to be somewhere between 15 and 20. They may never have had seizures, and then they may have their first seizure at that age.
So we have to be on the lookout
and
for
tell
those
the parents
patients.
Attention deficit, it's just treatment, how you diagnose and what the treatment
can't
options
read
are.
it.
It's too small to read.
And you all know about attention deficit.
And learning disabilities. So keep evaluating and treat, and make sure that the second they're diagnosed with epilepsy, they are put into a program at school that
Barbara's
addresses
program.
their learning needs. Yes.
The Arrowwood program.
And this is attentional. You can use stimulants, medications to treat attentional issues. It doesn't, for the most part, cause more seizures.
There was a fear many years ago that stimulants would make kids with seizures worse, but in fact, we don't feel that anymore, and we use this in combination. So we're not worried. There are a few children that if you give them too much, it will bring out a seizure, but you need to discuss that with the family. And genetics, we're going to let our colleague talk more about genetics, but the important part of genetics is it helps the family end their journey. or at least guide the journey. If you know what their disorder is and you can get a history of what other families have been through, it really helps a family move forward. Some of the genetic disorders, we don't have enough information to be able to tell the story of where we're going, but at least it's a good start. So we feel it's very important.
It also helps the parents not feel responsible for this as if it was their fault. As mothers, I think that oftentimes we feel that whatever happens to our child is our fault, and we shouldn't feel that. It also gives them access to support groups. So if they end up having a genetic abnormality, suppose they get diagnosed with TS, then they can meet all the other people who have children with the same genetic abnormality.
In the States, we had the same problem you had here, but in the States, we had private insurance where we had nobody would pay for the genetic testing. And then we were able to get a bunch of companies together to pay for free testing for under 3 years old, and we've expanded it up to 8 years old now in America. So everybody can get a small panel of about 300 genes, the most common genes, for free in the United States with sponsorship. We don't have a government insurance, and even the government insurance won't pay for it. But we're working on, changing that. I know you've been changing that here, trying to get the government to do more and more with the genetic testing. So there is a real future to this.
And this is just talking about which medications to use. You look at the comorbidities, so if they have a mood, you might use lamotrigine or oxcarbazepine, but you might avoid levetiracetam. So this is just an overview of how we make those decisions.
But the important part is that you need to educate the families and say, if we start this medicine and you see this problem, you might not see this problem, but if you do, let me know. So it's really important for the healthcare providers to educate the families to look out what to see with the medications, and that's really important.
And the other thing is to educate them that it's not necessarily the medication, that there are other things that can be causing it. You don't want anyone stopping the medication abruptly. So, summary.
So, in summary, we just want to say that anti-seizure medications can help some of the comorbidities, they can worsen some of the comorbidities, but it's important as a family member or a provider to be able to make sure that the healthcare providers know what are the underlying issues. Is there a learning disability? Is there an attentional issue? Is there epilepsy? And what would be the right medication for them? The academic issues should be monitored before treatment and during treatment. Very important to see what the progress is. The behavioral issues, the mood issues need to be discussed. The attentional issues need to be looked at before treatment and during treatment and every time you change treatment. And looking at sleep and quality of life. So these are the things that every child neurologist, neuropediatrics, primary care should be looking at with our children who have epilepsy. And thank you. And this is a famous Spaniard, Dr. Golgi, right? In 1965, drew. Oh, he was Italian? But he did this.
It's
Oh, no, it's Cajal.
Ramon.
That's Cajal. Sorry.
That's why
He's a
it's
good
in there,
Spaniard.
because it's Spanish.
We're fighting each other. We could bring up the last talk. Would you like this or would you like that?
Yes, I'll have this.
Yes. And to pull.
Thank you very much for your talk. I guess that in my talk I would be able to pass through some parts that you already have reviewed. I guess I should switch to Spanish since the audience is Spanish. Y muchas gracias a Pilar García de la Granja, a todo este magnífico equipo que tenéis en la Fundación Querer. Por supuesto también a GW Pharma, Jazz Farmacéutica por su apoyo. Y bueno, continuaré con, yo no sé si esto lo manejo yo o creo que no, que lo manejan desde la central, ¿no? Entonces continuaré sobre medicina de precisión y me centraré también, ya no en toda la epilepsia en general, sino en encefalopatías epilépticas. Es importante que revisemos un poco qué son las encefalopatías epilépticas, que es un concepto que se generó cuando no teníamos un gran conocimiento de las causas de la epilepsia y agrupan una gran cantidad de síndromes. Y recordar que el síndrome es como el síndrome gripal, no quiere decir mucho más que tienes una serie de síntomas. El síndrome gripal es que tienes fiebre, tienes dolor de articulaciones, moqueo, rinorrea, etcétera. Y el síndrome gripal no sabemos qué lo causa. Puede ser el virus de la gripe, un rinovirus, cualquier virus, puede ser incluso un COVID, ¿no? Y los síndromes en epilepsia es un poco lo mismo, es un agrupamiento de síntomas que en el caso de la epilepsia tienen unas ciertas edades de inicio y que es también uno de los elementos que te define un síndrome, la edad de inicio, el tipo de crisis, los hallazgos del electroencefalograma, si el paciente tiene discapacidad o no la tiene, etcétera. Es un conglomerado de síntomas que nos ha estado ayudando durante muchos años a poder establecer pronóstico y tratamiento, pero que hemos cometido un error, nos hemos frenado ahí, hemos parado en el síndrome, en vez de decir, bueno, ¿y por qué tiene el síndrome? Yo entiendo que en la gripe lo mismo te da que sea un virus de la gripe, que un rinovirus, que un adenovirus, porque al fin y al cabo te vas a casa con tu antitérmico y a los 7 días se te pasa. Pero en este grupo de población, buscar la causa es muy importante, y creo que toda la charla va a versar en busquemos la causa. Es cierto que dentro de esos síndromes hay algunos, como el síndrome de Dravet, que ya tenemos una causa muy bien definida, tenemos una causa definida en la esclerosis tuberosa, pero hay otros muchos que todavía no la conocemos y que afortunadamente estamos consiguiendo avanzar en ese camino. ¿Qué es una encefalopatía epiléptica? Se trata de una enfermedad que da lugar a una serie de manifestaciones en cognición, conducta, motricidad, lenguaje, diferentes áreas del neurodesarrollo, y que sobre ella la gravedad, la problemática que sufren estos pacientes va a incidir, por un lado, muy importante, la etiología, la causa, y vuelvo a la causa, que es lo más importante quizás de hoy. Por otro lado, también las crisis epilépticas. Las crisis epilépticas son síntoma, pero también perjudican en el neurodesarrollo. La repetición de crisis, la presencia de actividad epiléptica durante el sueño, por ejemplo, interfiere con el aprendizaje. La presencia de actividad epiléptica durante la vigilia interfiere con la atención. Por lo tanto, actuar sobre la actividad epiléptica y sobre las crisis es muy importante. Y luego la medicación, si damos medicamentos en dosis excesiva o una carga medicamentosa muy alta, estamos también interfiriendo con ese neurodesarrollo. Bien, la etiología no la podemos cambiar, aunque empezamos a diseñar tratamientos más dirigidos, pero lo que son las crisis, la actividad epileptiforme, la medicación, todo ello, al menos se pueden hacer cosas, se puede trabajar sobre ello, intentar manejarlo. Y dentro de las encefalopatías epilépticas y el desarrollo, siempre hemos podido diagnosticar sencillamente por la historia clínica y la resonancia magnética muchas de ellas, ¿no? Aquellas que tenían que ver con sufrimiento perinatal al nacer, las hipoxias perinatales, traumatismos craneoencefálicos, meningitis en la infancia, muchas de ellas dieron lugar a síndromes de West, síndromes de Lennox-Gastaut, esos síndromes que he puesto al inicio. Otras se veían por displasias o malformaciones congénitas amplias, trastornos de la migración neuronal, el neurodesarrollo en algún momento de principalmente el primer trimestre o por algún tipo de mutación genética había dado lugar a problemas. La esclerosis tuberosa también la diagnosticábamos así, pero existía un gran porcentaje de encefalopatías del desarrollo que no podíamos diagnosticar hasta que llegó la genética y sobre todo cuando llegaron la genética avanzada, ¿no? Y a partir de ahí hemos encontrado cómo 1 de cada 2.000 habitantes pueden tener esa larga lista de genes que dan lugar a encefalopatías epilépticas. A la cabeza de todas está el SCN1A. El SCN1A es la mutación que se ha relacionado con el síndrome de Dravet. Y el síndrome de Dravet hemos identificado que ese tipo de mutación es muy mal tolerado, es un gen que tiene que estar muy bien conservado y cuando se producen mutaciones en él da lugar a enfermedad con mucha probabilidad y la principal es el síndrome de Dravet. Hay otros que tienen otro tipo de fenotipo, pero el síndrome de Dravet es el más prevalente. De hecho, se empieza a hablar de una incidencia de 1 en 10.000 habitantes, es decir, casi sale ya de lo que serían las enfermedades raras por la frecuencia tan alta que tiene. Pero hay muchas otras y es importante identificarlas. ¿Por qué? porque ese es el primer paso para poder establecer medicina de precisión. Hablamos de medicina de precisión cuando analizamos los factores fisiológicos, el genotipo, el estilo de vida, los factores medioambientales, incluso el microbioma. Intentamos con ello buscar soluciones más específicas que incluyen la genética, la enfermedad y las características del paciente. Estamos todavía muy lejos de ello, pero sí hemos avanzado mucho en conocer fisiología y genotipo. Y todo eso nos permite pues, buscar y encontrar susceptibilidades precisas a determinadas enfermedades, buscar marcadores diagnósticos para hacer estos tratamientos de precisión, ver el pronóstico y monitorizar la respuesta al tratamiento. ¿Y en qué consiste que los tratamientos de precisión? Van desde reposicionamiento de fármacos, es decir, tú tienes una hipótesis basado en una anomalía genética, basado en una fisiopatología, por ejemplo, las encefalopatías autoinmunes, cómo se han movido todos los fármacos de la reumatología para tratar el síndrome de Rasmussen, el FIRES, el NORSES, son epilepsias que tienen un debut catastrófico a partir de algún tipo de anomalía en el sistema inmunitario que genera anticuerpos contra diferentes receptores del sistema nervioso central o genera, con el caso de FIRES, una respuesta autoinmune natural que no se mide con anticuerpos, y ahí se han desarrollado, por fin, y después de mucho trabajo, estudios que demuestran que el tratamiento precoz con ciertos fármacos dirigidos a inmunomodulación, como pueden ser rituximab, anakinra y otros muchos, pueden mejorar estos cuadros. Eso es un reposicionamiento de fármaco por la vía de la inmunidad, pero hay muchos reposicionamientos de fármacos basados en mecanismos de acción dirigidos a la hipótesis que la anomalía genética ha detectado. Por ejemplo, pues puede ser el cannabidiol, fenfluramina y otros fármacos que iré comentando. Y, por supuesto, buscar ya terapias dirigidas por vía genética, pues los oligonucleótidos sin sentido que van a potenciar la expresión en enfermedades que se producen en heterocigosis, la expresión del gen sano y van a reducir la expresión del gen enfermo. Pero ahora tenemos un gran desafío y es que si esto no se hace pronto, los resultados bajan muchísimo. Y aquí os voy a presentar algunos trabajos que van a dar importancia a esta frase del tiempo es cerebro, ¿no? El tiempo es cerebro se habló mucho en el ictus. En el ictus había que actuar rápidamente porque cada minuto que pasa incrementaba la muerte neuronal, incrementaba la apoptosis. Y de alguna manera se olvidó esto en epilepsia. Si bien en la época del síndrome de West se hablaba del síndrome de West hay que tratarlo pronto porque si no estos niños no van tan bien como si tardas en tratarlo. Pero eso de alguna manera se perdió y entramos en un nihilismo de la enfermedad está ahí, da igual cuando empieces, el problema ya está establecido. Pues no es así del todo. Este es un trabajo que mostró cómo en pacientes que habían sido diagnosticados de síndrome de West, de espasmos infantiles, pronto, comparado con aquellos que fueron diagnosticados tarde, 2 meses después, cuando se midió su capacidad cognitiva al cabo de unos años, se vio como los que tenían el diagnóstico tardío tenían peor capacidad cognitiva. Y esto viene al caso, pues algo que comentaron, que es como esos episodios iniciales que se dan en los espasmos infantiles de pequeñas alteraciones, con mucha frecuencia son pasados por alto y no se busca al médico que puede diagnosticarlos, el neuropediatra que sabe que cuando un niño pega pequeños respingos y se queda bloqueado unos instantes, puede ser un síndrome de West, ¿no? Y el retraso del diagnóstico, como vimos en este estudio, también en el síndrome de Dravet, lleva a que aumenta el número de fármacos inadecuados que se usan. Yo creo que el síndrome de Dravet está mejor enfocado ahora, pero hasta hace unos años los niños con síndrome de Dravet con frecuencia recibían fármacos inadecuados, como eran bloqueantes de canal de sodio. Esos fármacos inadecuados dan lugar no solo a no controlar la epilepsia, sino a empeorar las crisis, como veremos luego. Cuanto más tiempo pasa sin saber que ese niño tiene un síndrome de Dravet, más probabilidad hay, como vimos aquí, de que se usen fármacos inadecuados. La utilización de fármacos inadecuados en este otro estudio también se correlacionó con un cociente intelectual menor al cabo del tiempo. Es decir, aquellos niños que habían recibido el fármaco correcto desde el inicio tenían como media mejor desarrollo cognitivo que aquellos que habían recibido fármacos inadecuados. Es decir, vuelvo a la diapositiva de las primeras, la epilepsia persistente lleva consigo afectación neurocognitiva y el pararla cuanto antes mejor. También en el caso del Dravet, que nos ha enseñado mucho, en algunas ocasiones se encontraron pequeñas anomalías en la resonancia magnética que llevaron a que estos pacientes fuesen tratados con cirugía de epilepsia. Y ya en este trabajo avisaban, cuidado, que a veces la resonancia magnética anómala es un hallazgo que no tiene nada que ver con la epilepsia y en el fondo es un síndrome de Dravet. Y esta es una serie en la que algunos que se operaron tuvieron un pronóstico muy malo. Entonces, ¿dónde vienen esas terapias de precisión? Pues viene a partir del paciente y el estudio genético, el hallazgo de la causa y buscar estrategias que te permitan conocer qué quiere decir esa mutación. En el caso de las canalopatías es muy importante a lo mejor identificar aquellas que producen ganancia de función o pérdida de función, es decir, una canalopatía del potasio que hace que el canal del potasio funcione más, puede tener un tratamiento actuando sobre el canal del potasio, bloqueándolo. Una canalopatía del sodio, como el síndrome de Dravet, que habitualmente da lugar a que el canal de sodio pierde capacidad de función, funciona peor, hay pérdida de función, pues evidentemente darle bloqueantes de canal del sodio no es una opción. Y mediante esa vía y mediante diferentes procesos de análisis previo, pues se pueden establecer ya tratamientos dirigidos a la enfermedad. Y esa es la idea que hay detrás. Hay una serie de enfermedades donde esto a lo mejor ha avanzado más, o se ha intentado avanzar más. Una de ellas es la esclerosis tuberosa, ¿no? La esclerosis tuberosa tiene la ventaja de que la mayoría de los niños son diagnosticados precozmente, incluso prenatalmente. Muchos niños ya aparece un pequeño rhabdomioma en el corazón y nada más nacer ya se sabe que tiene una esclerosis tuberosa. Por eso ha sido un modelo que ha permitido ver la evolución de la enfermedad antes de que aparezca la epilepsia. Y ahí pues han visto cómo diferentes formas de tratamiento pueden mejorar el pronóstico. Y en concreto la vigabatrina de uso precoz parece que puede ser una opción, pero también se ha intentado con fármacos dirigidos a la vía emetor, como es el everolimus, que potencialmente podrían reducir esa formación de conexiones aberrantes que es detrás de todo lo que hay en esas redes epilépticas, que al fin y al cabo, una vez que se establecen, son difíciles de eliminar, ¿no? Y, por ejemplo, hay muchos estudios, o no muchos, pero hay suficientes estudios para ver cómo existe una correlación entre la actividad epileptiforme que se detecta en el electroencefalograma y la evolución, de tal manera que cuando hay anomalías epileptiformes, pronto hay mayor probabilidad de que tengan disfunción cognitiva, de que tengan trastorno del espectro autista. Y cuando la epilepsia ya, que es posterior a eso, normalmente ves primero anomalías en el electro y después aparece la epilepsia, pues cuando ya la epilepsia se establece hay mayor discapacidad intelectual. Eso parece que nos abre una ventana de tratamiento, una oportunidad de tratamiento, ¿no? Aquí veis en esta serie cómo cuando el electroencefalograma es normal, todos estos que están en blanco, no hay crisis epilépticas. Algunos que tenían electroencefalograma normal, veis estos rombos negros, se producen las crisis epilépticas. Pero fijaros que la mayoría de los que tienen crisis epilépticas eventualmente en el tiempo venían de tener electroencefalogramas anormales mucho tiempo antes. Es decir, el electroencefalograma sirve para ayudarnos a decir, este paciente va a tener crisis epilépticas con una fiabilidad muy alta, con un valor predictivo casi del 100%, positivo. El que no lo tengan puede ser que haya crisis, pero si tienen anomalías tarde o temprano las desarrollarían. A partir de ahí se hace este estudio. Un estudio en el que se analiza, se llamó EPISTOP, se analiza si tratamos a estos niños con esclerosis tuberosa con vigabatrina antes de que empiecen las crisis epilépticas, pero sí a partir de que tengan anomalías en el electroencefalograma, ¿qué va a pasar con ellos? Y esto se randomizó en dos grupos, unos con tratamiento preventivo en azul y otros que no se les hizo el tratamiento. Y fijaros la diferencia entre las gráficas en cuanto a la probabilidad de una vez que debuta la epilepsia estén libres de crisis o con el tiempo libres de crisis. Muchísimo mayor, 3 veces mayor en el grupo que se les dio vigabatrina. Y no solo eso, sino también la evolución cognitiva fue superior cuando se les dio vigabatrina y fue raro que desarrollasen trastorno del espectro autista. De hecho, yo creo que este grupo, este estudio, nos ha avisado que a los pacientes con esclerosis tuberosa debemos revisar con electroencefalografía regularmente y muchos ya estamos iniciando vigabatrina en el momento en el que notamos que hay actividad epileptiforme, ¿no? Ha sido un estudio que ha marcado una diferencia y que nos sirve a lo mejor para pensar que en otras enfermedades también se da esa ventana de tratamiento que tenemos que aprovechar y que no estamos siendo capaces de hacerlo. Es decir, lo que ocurre en la esclerosis tuberosa probablemente es extrapolable a otras epilepsias. ¿Cuáles? Hay muchas que podemos hacer tratamientos de apoyo. Por ejemplo, todas estas epilepsias que se llaman SLC son transportadores de... Los SLC son transportadores de nutrientes, de sustratos al sistema nervioso central. La que más conocemos es la SLC2A1 y sabemos que la dieta, que es el transportador de GLUT1, transportador de glucosa por la barrera hematoencefálica, y sabemos que estas enfermedades mejoran mucho con la dieta cetogénica. De hecho, es el tratamiento de elección. Y es importante detectarlas precozmente porque la dieta cetogénica utilizada pronto mejora cognitivamente, disminuye el desarrollo de distonía. Algunas son epilepsias leves, otras más graves, y es importante su detección ante estos pequeños síntomas que te ayudan, como son distonía, distonía al correr, distonías estáticas y también las crisis epilépticas, que a veces son crisis de ausencia, refractarias al tratamiento común con valproico, etosuximida. Pero hay otros transportadores de creatina que pueden beneficiarse de cantidades elevadas de creatina, transportadores de galactosa, de piridoxina, ácido folínico. Muchas de ellas ya las conocíamos y las detectábamos mediante estudios metabólicos, pero hoy en día, con un exoma amplio o con un panel amplio, podemos detectarlas genéticamente de una manera más sencilla. Por otro lado, tenemos también una serie de enfermedades que ya hemos descubierto que tienen un tratamiento más eficaz. Por ejemplo, levetiracetam en STXBP1. Hay muchos de estos que poco a poco iré comentando. Y entonces, todo esto nos lleva a esta forma de medicina de precisión, que es, por una parte, reposicionar fármacos, elegir el fármaco antiepiléptico adecuado, tratamiento quirúrgico dirigido, tratamiento sustitutivo, terapias metabólicas y terapia génica. Ejemplos. Pues mira, el everolimus es un tratamiento que se ha visto eficaz en disminuir esa conectividad neuronal y por lo tanto ha tenido su posicionamiento en las enfermedades de la vía mTOR, como es la esclerosis tuberosa. De nuevo aquí, los estudios de everolimus muestran mejoría comparado con placebo, pero de nuevo las mejorías no son muy potentes. Quizás, de nuevo, porque la ventana de oportunidad es tardía. Estos son pacientes que habían fallado ya otros tratamientos y para entrar en estos ensayos clínicos tenían que haber probado pues vigabatrina, CTH y otros fármacos antiepilépticos. Es decir, que si se tratasen pronto posiblemente sea diferente. La vía mTOR también tiene relación con trastornos de la migración neuronal, con displasias corticales, y muchas veces son displasias ocultas. Las displasias ocultas son un poco de los quebraderos de cabeza de la cirugía de epilepsia. Sabemos que una epilepsia es focal, tenemos idea por la semiología y el electroencefalograma dónde está el foco, pero vemos resonancia magnética normal y resonancias de muy buena calidad, miramos ahí y es normal. Estos pacientes hoy en día los podemos aproximar mediante estereoEG y buscar el foco, y la estereoEG puede ser muy eficaz en muchos de ellos, pero se plantea que a lo mejor eso ya es un poco matar moscas a cañonazos, que quizás existirían otras vías como terapias dirigidas en la vía mTOR para prevenirlo. Por cierto, las displasias corticales muchas veces tienen una base genética general, como por ejemplo mutaciones en el gen DEPTC5, que da lugar a una facilitación de que se produzcan anomalías en el desarrollo de la corteza cerebral, quizá porque la vía mTOR está afectada de forma desigual. Pero también las displasias corticales pueden surgir de mutaciones somáticas, y eso es uno de los grandes problemas que tenemos en genética, y es que estamos estudiando las mutaciones iniciales, pero no somos capaces de saber si a partir de una neurona en formación se ha producido una mutación que da lugar a una malformación localizada, ¿no? Y eso se sabe que ocurre y lo difícil es ahora acceder a ellos. Reposicionamiento fenfluramina. La fenfluramina es un fármaco que se ha aprobado en algunos países ya para utilizar en el síndrome de Dravet y en vías de Lennox-Gastaut, y viene de reposicionamiento de un medicamento que se vio muy eficaz en el tratamiento de algunas epilepsias fotosensibles y que inicialmente se utilizó para tratar la obesidad. Ese fármaco desapareció porque tenía un riesgo alto de producir fibrosis cardíaca, pero se ha retomado con dosis menores en otra población, se ha vigilado, esto no está ocurriendo, son pacientes que no están sufriendo fibrosis valvulares y parece que es un fármaco seguro para poder utilizarse en esta población. Y tiene unos datos en los ensayos clínicos que prueban su eficacia, lo mismo también que el cannabidiol. El cannabidiol, ya habéis oído sobre él, y es un fármaco eficaz en síndrome de Dravet y síndrome de Lennox-Gastaut, y ahora nos queda determinar cuáles son los que genéticamente tienen más probabilidad de responder. Por ejemplo, las mutaciones en los genes GRIN relacionados con el receptor NMDA son mutaciones frecuentes que dan lugar a diferentes síndromes como encefalopatías epilépticas, punta onda continua durante el sueño lento y otros muchos. Ese aumento de función del receptor NMDA es lo que está en la fisiopatología de estas mutaciones muchas veces. Y contamos con fármacos como son la memantina, que se han utilizado en la enfermedad de Alzheimer, que pueden suprimir un poco ese aumento de la función. Es decir, ahí se abre otra vía de terapia dirigida mediante reposicionamiento de un medicamento del Alzheimer a un tipo de encefalopatía epiléptica. Otra forma de reposicionamiento pues, fue el estiripentol en el síndrome de Dravet. El síndrome de Dravet tuvo un fármaco que se aprobó hace ya 15 años, el estiripentol, y que venía de tratar epilepsias focales con poca eficacia, se probó en el síndrome de Dravet con muy buen resultado. Y nosotros hemos podido trasladar esto y hacer otro reposicionamiento a otras encefalopatías epilépticas y vemos que también puede ser eficaz en algunas otras encefalopatías que se pueden parecer al síndrome de Dravet y que no tienen hoy en día ningún tratamiento específico, ¿no? La 4-aminopiridina se ha utilizado en pacientes que tienen mutaciones en el canal del potasio que dan lugar a ganancia de función. Es un fármaco que bloquea el canal de potasio. Una vez que uno identifica en un niño una mutación en canales de potasio, especialmente KCNQ2 y KCNT, en estos casos se puede hacer un análisis de si esa mutación da lugar a una ganancia o pérdida de función. Si es una pérdida de función, ni se nos ocurre utilizarlo, porque empeoraría el cuadro, al bloquearlo todavía más. Pero si es una ganancia de función, podría funcionar. Y como veis, la lista es muy extensa y vamos viendo poco a poco cómo los diferentes canalopatías podemos identificar si son ganancia o pérdida de función y con ello diseñar algunos tratamientos. Y algunos de ellos no van a venir solo del hecho de encontrar la correlación, sino de lo que observamos de otros pacientes. Por ejemplo, aquí en las KCNQ2 con pérdida de función sí se ha visto que puedes, y se ha visto empíricamente por ver otros pacientes, que los bloqueantes de canal del sodio pueden ser eficaces en ellos. De alguna manera, esa alteración en el canal del potasio puedes restablecer el equilibrio neuronal actuando sobre el canal del sodio y de alguna manera encontrar un mejor control que tendrías con otros medicamentos. En KCNQ2, por serendipia, se ha visto cómo la gabapentina, que es un fármaco que teníamos olvidado, puede dar lugar a mejoría. También, de nuevo, los bloqueantes del canal del sodio pueden ser eficaces en este grupo de pacientes. Otros más, pues por ejemplo, en STXBP1 se ha visto como el levetiracetam, y ya hay varios artículos que lo demuestran, puede ser un fármaco más eficaz y en principio en el STXBP1 debuta muchas veces como un síndrome de Lennox-Gastaut. No tienes otros parámetros que te digan esto va a ser esta mutación y necesitas hacer este estudio genético e insistir en el levetiracetam, que en el síndrome de Lennox-Gastaut no lo tienes de primera elección, ¿no? PCDH19, lo mismo. Levetiracetam es un buen fármaco en PCH19 y esto se ha encontrado y aquí quizá pues romper una lanza a favor de las asociaciones de enfermos. Esto surgió de información que proporcionaban asociaciones de enfermos de PCH19, que cuando mostraron la casuística que tenían de diferentes miembros del grupo, pues se vio cómo después muchos de ellos de haber pasado por muchos fármacos fue cuando empezaron levetiracetam que sus crisis se controlaron. Es decir, aquí andamos viendo cómo la genética también abre otra puerta, que es la de establecer un colectivo de pacientes con el mismo problema y a partir de la historia de estos pacientes, como si hiciésemos un poco antropología de epilepsia, extraer información que vas a poder aplicar al resto de los pacientes. Otra de las grandes virtudes de tener estudios correctos. La cirugía, recordar que es uno de los primeros tratamientos que demostró la importancia de hacerlo precozmente. Muchos trabajos mostraban que la cirugía antes de los 5 años, cuando es eficaz, tiene muchas probabilidades de conseguir el control completo de las crisis o incluso poder dejar la medicación. Mientras que cuando llevaban más de 5 años de epilepsia refractaria, esas probabilidades bajaban mucho. Entonces, la cirugía precoz debe considerarse. Ya han salido una serie de síndromes que podemos identificar mediante estéreo Eeg, que la resonancia magnética puede ser normal, pero que son subsidiarios de cirugía y de mejorar con esta tratamiento. Y la cirugía cada vez la hacemos con más precisión también, de tal manera que hoy en día mediante estereoelectroencefalografía, muchas veces apoyada en técnicas de diagnóstico neurofisiológico como es el análisis de fuentes mediante estudio de numerosos electrodos sobre la corteza cerebral que nos permite localizar con más precisión, pues se pueden hacer a veces con formas menos invasivas. Y en el caso de la esclerosis tuberosa permite muchas veces identificar el túber enfermo o los túberes enfermos y hacer terapias dirigidas mediante el mismo procedimiento con termocoagulación o mediante láser, como hacéis vosotros a menudo. Bien, terapias metabólicas, que ya he ido sobre ellas. Hay otras, como puede ser la D-galactosa. La D-galactosa es un tratamiento que se está postulando como especialmente eficaz en algunos pacientes, sobre todo los que tienen mutaciones LC35A2, que a veces son mosaicismos y son difíciles de identificar y los identificas por algunos hallazgos en la resonancia. Y luego terapias génicas, que no entraré mucho en ella, puesto que vamos a tener una charla específica en ella, que van desde los oligonucleótidos, mediante terapias génicas dirigidas con vectores virales a inyectar el ADN y modificar con eso la expresión de la proteína. Y ya en epilepsia tenemos un tratamiento bastante avanzado, que es el tratamiento dirigido por Stoke de un oligonucleótido contra SCN1A, y otra forma que ya es una terapia génica mediante vectores virales o adenovirales, que está en una fase avanzada. Bien, concluyendo, la medicina de precisión parte de un estudio que tiene que ser pronto y correcto. Y es fundamental, como decía, ese tratamiento, ese diagnóstico y tratamiento precoz, porque estamos un poco contrarreloj. Es un cerebro inmaduro que tiene una gran proliferación neuronal, una gran capacidad de sinaptogénesis y una gran capacidad de producir conexiones aberrantes. Tenemos que tener el diagnóstico claro para evitar errores de tratamiento que hoy en día se pueden prevenir, y con ello vamos a reducir la afectación progresiva por el epileptogénesis, y eso está en continuo desarrollo. Hay que estar muy atento. Como veis, esta charla hace 5 años habría 2 o 3 diapositivas. Hoy en día, como veis, es un poco demasiada información, pero creo que es importante que todo el mundo sepa que hay mucho en marcha. Y muchas gracias por vuestra atención. ¿Qué hacemos?
Muchas gracias, especialmente por la extraordinaria capacidad de síntesis de los 3 doctores para algo tan complejo, poder resumirlo en tan breve espacio de tiempo. ¿Hay alguna pregunta de la sala, por favor?
Normalmente los padres tenemos mucho miedo a las operaciones, ¿no? A que Normalmente los padres tenemos mucho miedo a las operaciones, creemos que estamos todavía probablemente hace 20, 30 o 40 años en cuando se hablaba de lobotomías y todas esas cosas a la hora de tratar la epilepsia. Sin embargo, esto ha mejorado muchísimo y las nuevas maneras de operar, no solo de precisión con láser o directas, incluyen incluso poner algún tipo de aparatos en los cerebros que pueden cortocircuitar estas crisis epilépticas, ¿no? ¿Cómo nos enfrentamos a esto? ¿En base a qué se toman este tipo de decisiones? ¿Y cómo podemos explicar a los padres que el cerebro también se puede operar sin necesidad de que el niño sufra unas consecuencias adversas graves como estamos acostumbrados en la literatura probablemente errónea a reconocer, ¿no?
Bueno, se puede operar lo que se debe operar, y si las cirugías están bien indicadas y se hacen las resecciones lo mínimo necesario, pues ahí podemos los médicos transmitir tranquilidad al paciente y decirle debe operarse porque la alternativa es peor. Hay luego un grupo de pacientes que está clarísimo que no se deben operar porque no está localizado el foco, o son focos muy extensos, o están en zonas del cerebro que no se pueden tocar porque está el lenguaje, movimiento, etcétera. Y en estos casos pues también es muy importante ser claro con los padres. Ahí nos queda luego entre medias ese grupo en los que uno le gustaría no tener que operar, pero ves que hay opciones de mejoría y que la alternativa ya está demostrando no ser buena, que son aquellos pacientes que han probado a lo mejor 8, 9, 10 fármacos, no han respondido, les estás dando los fármacos más eficaces que han salido recientemente al mercado y tampoco estás viendo respuesta. Y esas son decisiones difíciles y el médico pues muchas veces no transmitimos una gran seguridad a los pacientes. Y luego yo creo que you can talk about devices, electronic devices for treating these patients.
Yes, well, I think first we hope you all come back next year because next year we will present our research that we are using on devices. Some of our papers that just came out, but neurostimulation, whether it be through a nerve in the neck, the vagus nerve, or directly into the brain, we are now able to, in some patients, find the spot where it's coming from, and some that we can't, where we're stimulating directly deep into the thalamus. So come back next year so we can tell you more about what we're seeing.
Entonces, una segunda pregunta sobre el cannabidiol y estos nuevos medicamentos sobre el cannabidiol y los nuevos medicamentos que están saliendo que vienen de la marihuana y que llegan 6 años después a Europa. Se van a recomendar aquí, Antonio, ¿qué experiencia tenemos en Estados Unidos?
Cannabidiol ahora va a estar aceptado para uso en síndrome de Dravet y síndrome de Lennox-Gastaut. En principio sí, bueno, y esclerosis tuberosa. Estas 3 indicaciones tiene. Se debe utilizar. Son pacientes que evidentemente no es lo primero que vamos a administrar, pero tienen un número de tratamientos limitado. Hoy en día para el síndrome de Lennox-Gastaut pues a lo mejor hay 3 o 4 fármacos que tengan aprobación específica para el síndrome de Lennox-Gastaut y para Dravet de una situación similar. Si esos fármacos no han funcionado, lo lógico es darle una oportunidad a este paciente a que mejore con estas nuevas terapias.
Yo quería hacer... Sorry.
So we have been lucky to start some of these medications here in the United States, and we have seen good results, and sharing it with Antonio, he's doing the same research projects as we are. It does take longer. It is frustrating that you don't have the drugs yet. Some drugs you had before we had. We didn't have steripental, we didn't have clobazam. The EU had it before we did. So there is a back and forth. But we hope that everybody will be able to get treated with all these medications, and we're spreading our education across the seas.
Sí, aquí hay una pregunta.
Buenas tardes y muchas gracias, muy interesante. Voy a aprovechar que sois grandes profesionales para haceros una pregunta que me preocupa. Tengo una niña con una enfermedad rara, bueno, tiene 2. Una de ellas es el síndrome de Angelman, no sé si lo conocen. Y entonces, una cosa que me atormenta mucho, soy neuropsicóloga también y conozco los efectos secundarios de la medicación, es que le dan ácido valproico. Entonces, sé que en Norteamérica y en Sudamérica no se usa apenas el ácido valproico. Quería preguntar por qué en España es como de primera elección para el Angelman, si en otros países no, o sea, se ha como descatalogado o no se usa.
Bueno, el ácido valproico tiene un poco un perfil de ser un fármaco eficaz en todo el síndrome de Lennox-Gastaut y parecidos. El Angelman un poco se parece a un síndrome de Lennox-Gastaut en que tiene una punta onda lenta en el electroencefalograma. Muchas veces has puesto el medicamento antes de saber el diagnóstico. Yo no sé si en tu hijo fue así.
En mi hija empezaron con Ketra,
sí.
Tenía mucha crisis de ausencia, sobre todo, tenía sobre todo crisis de ausencia, ya con 2 años y medio, porque desde pequeñita tuvo muchos espasmos, pero no se diagnosticó nada. Entonces le pusieron Keppra y para evitar las ausencias, que es verdad que se le quitaron, le dieron ácido valproico, pero bueno, tiene la tiroides pues bastante mal, claro, debido al ácido valproico.
Bien, entonces el ácido valproico retirarlo a veces también es difícil, porque aunque aparentemente no está resolviendo el problema, vamos, no lo está resolviendo, pero puede estar haciendo algo. Entonces yo me imagino que los médicos les cuesta quitar un fármaco que se ha usado mucho en el síndrome de Angelman. Hay otros fármacos que se han usado en el síndrome de Angelman como etosuximida, topiramato, y normalmente lo que haríamos en una consulta de epilepsia es ir asociando al ácido valproico y en función de la respuesta decidir qué hacemos con el fármaco que ya estaba, retirarlo o mantenerlo. En Estados Unidos se usa menos el ácido valproico, yo creo que mejor te comenta el doctor Wolf.
So we do use valproic acid. You pick different cases, but I think what your real point is us healthcare providers need to listen to the parents. If there's something that you're worried about with the medication, then reevaluate and maybe try a different medicine. You could always go back to, say, valproate. So sometimes we have families, even though we think that is the best medicine, we have families that want to try something different.
And sometimes you go back and you try a medication that you've tried and failed before. Sometimes you look at different combinations of medications. So if there's an issue, go back and ask them, is there a different combination or a different medication to use?
And this is about a personality of your healthcare provider, your neurologist, if they're willing to listen. And some in America don't. And so in America, people just pick up and they go to the next neurologist and they say, I want to take my child off the medicine and see what they look like off this medicine or on this medicine. So we think it's very important, being parents, to listen to the mothers and try different things, because we know that we don't know everything and we don't know how your child's going to react to a different medication. So we hear your frustration, but we still think valproic is a very good medication.
No, la verdad es que ella no tiene crisis, o sea, ella no tiene crisis. El problema es que un neurólogo nos retiraba el ácido valproico para evitar los problemas de tiroides, pero claro, otro neurólogo nos dijo que ni se nos ocurriera, que qué queríamos, que la niña tuviera crisis o que estuviera medicada para la tiroides. Y bueno, yo como madre tomé la opción de que no tuviera crisis, entonces espero no haberme equivocado, no sé.
Yo creo que no te has equivocado. El tiroides se maneja bien con hormona sustitutiva y todos los internistas te dicen, manejar el tiroides es muy fácil. Pero la epilepsia no es fácil y no tienes 100 alternativas, tienes pocas.
Había otra pregunta ahí.
Sí, yo quería preguntar esto. A ver, cuando los neurólogos veis a casos como los de niños, como los que estamos hablando, ¿no establecéis una relación de causalidad entre el Eeg anormal y las consecuencias? Digamos, bueno, lo que los padres entendemos como consecuencias. Siempre habláis de que el mismo Eeg da resultados completamente diferentes, de que la misma anormalidad da resultados diferentes en diferentes niños. Y yo siempre me pregunto, ¿no? ¿Dónde está la relación de causalidad entre un Eeg normal o anormal y el tipo de retrasos, problemas, consecuencias que sufren nuestros niños? No estoy seguro de que tenga respuesta, pero...
Do you want to start? Go ahead.
That is a great question. We don't have an answer for you. I'm sorry, Alfredo. And the fact that the clues that we have, whether it's an EEG or an MRI, doesn't tell the whole story. And that's what makes this so frustrating. And the genetics is helping us a little bit, but it's all not giving us the answer. So I think that is to be continued, why every child is so different.
Yeah.
Me gustaría añadir otra pregunta que enlaza con esta que acabo de hacer. Sí, ¿no está encendido? No. ¿Ahora? Ahora sí.
Habla más alto.
Aquí hay una, vale, de acuerdo. Quería hacer una pregunta que enlaza justamente con esta, y es que en las encefalopatías epilépticas, es decir, aquellos síndromes que cursan con una epilepsia y además un deterioro en otras funciones cognitivas, motoras, como ha explicado el doctor Gil-Nagel y también los doctores Wolf y McGoldrick. La pregunta es, o la consideración es, sabemos que aunque mejore la epilepsia, no necesariamente va a mejorar las otras alteraciones que causan este síndrome. Entonces creo que esto es algo que quizás habría que insistir en la sala, que es cierto que si no controlas la epilepsia vas a empeorar el pronóstico cognitivo, pero también es cierto que aun mejorando la epilepsia es posible que no incidas porque ese gen, ¿no? Explíquenlo ustedes mejor que yo.
Yo creo que aquí de nuevo hay que individualizar y podríamos hacer un debate de horas sobre el electro en epilepsia, lógicamente. Yo os he mostrado una diapositiva de cómo el electroencefalograma en la esclerosis tuberosa predice quién va a tener epilepsia y quién puede tener más riesgo de trastorno del neurodesarrollo. Y ya ahí se está estableciendo un cambio de paradigma y los pacientes con esclerosis tuberosa cada vez se hace más electroencefalografía y en cuanto aparecen alteraciones a muchos de ellos se les pone vigabatrina a partir del estudio de Epistop. Por otro lado, cuando decimos un electroencefalograma, parece que el electroencefalograma es un tipo de prueba estándar. Un electroencefalograma de 30 minutos da 30 minutos de información, uno de 3 días da 3 días de información. En el caso de la esclerosis tuberosa y el síndrome de West se ha establecido que se deben hacer electroencefalogramas de un mínimo de 6 horas para poder tener información suficiente y aplicar estos conocimientos. Muchos electros que se están haciendo son de 30 minutos, o de que el niño se quede en casa, que no duerma en toda la noche y luego a ver si hay suerte y se duerme en el laboratorio, que tampoco es necesario hoy en día eso. Con lo cual, si hacemos electroencefalogramas más exhaustivos, por ejemplo, en la punta onda continua durante el sueño lento vamos a reconocer más pacientes con eso. Y en punta onda continua durante el sueño lento sí se ve cierta correlación, ¿no? I don't know if you agree with that in Landau-Kleffner syndrome and POX, SS in English, vemos más correlación entre la capacidad cognitiva del niño y el electro. Y de hecho lo usamos como un marcador, como muchos de estos niños son tratados con corticoides en bolo cada mes o mes y medio, usamos como marcador el electroencefalograma durante el sueño profundo para ver si están yendo bien o no. Pero efectivamente luego en un montón de casos, y yo te diría casi la mayoría, no conseguimos ver esa correlación.
Bueno, si no hay más, otra pregunta, sí.
Sí,
ah,
sí.
Bueno, ahí hay otra. Luego abusas.
Se ha mencionado la microbiota. ¿Qué estudios se están haciendo sobre el cerebro entérico y la microbiota con respecto a las epilepsias? ¿O qué conocéis?
Well, I think we should answer both because I think this is a growing area. Estamos empezando a estudiar la microbiota y es muy compleja y poder sacar conclusiones ahora pues no se puede, pero yo creo que dentro de 5 o 10 años vamos a tener ya datos que nos van a permitir encontrar patrones de microbiota y mediante inteligencia artificial, con genética, fármacos, datos del estilo de vida, medidores de sueño y demás, probablemente en todo ese conjunto sí encontraremos que hay algo ahí que nos permite incidir con terapias, con tratamiento, con recomendaciones. Pero es futuro, no es presente. Bueno, sí estamos haciendo estudios, pero de ahí a sacar conclusiones que os llevéis un mensaje, si tienes esto, toma esto, que es lo que al fin y al cabo queremos, queda todavía tiempo. Pero sí, ese estudio es fundamental.
Tu pregunta y acabamos.
¿Puedo abusar?
Sí.
Es sobre los neurólogos infantiles y cómo diagnostican a los niños, ¿no? Cuando hay pruebas objetivas, está claro cómo funciona todo. Veis un EEG y tenéis una idea de lo que puede estar pasando. Pero muchas veces necesitáis saber cómo se comporta el niño, cómo está el niño. No necesariamente si tiene un ataque epiléptico o no, sino si está más listo, más torpe, más cosas que no se pueden medir con un aparato. Y yo siempre tengo esta impresión de que los neurólogos tenéis una visión de segunda mano de lo que le pasa al niño. El niño tiene un comportamiento, los padres lo aprecian con sus propios sesgos, vamos a decir. Y incluso los padres pueden ver dos cosas diferentes. Y entonces vosotros tenéis una noticia de segunda mano de cómo está el niño. ¿Es suficiente como para saber cómo están los niños?
So, Patricia, Stephen.
So what I mean is, you have a second-hand vision of how the kids are, because you are not you know the objective things, of course, the EEG, you know, right? Okay, but then about how the kid is, you can only know if you see him, right? What you have is a second-hand version of that, which is how the mother or the father sees him, which is not objective, right? You can put a lot of your own vision in how you transmit this information to the doctor.
So part of what we talked about is how important it is to talk to both parents, to talk to the child, and to get reports from school. The other thing which actually has changed during COVID is we at least are using a lot of telemedicine. So that the good aspect of that, maybe one of the only good things to come out of COVID, is that we are able to have more visits with the patients more frequently, and we can see into the house. And that has changed a lot, because you can see when a child comes into our office, they're upset, they're crying, they're bored. And if we can look at them in their own environment in the house without a written report from the teacher, then we can see, we have a better idea of what's going on, what they're playing with, how they're interacting with their siblings. So what we've done is we're seeing them more often, maybe for a shorter period of time, but we can sort of get a better picture of what their day-to-day life is like. And I think that's hard for us if we don't see them in their own environment. Part of the things that we struggled with were the children and the adults who were living in facilities, and they would come with a caregiver who didn't know the patient, who would say, oh, I never really worked with them before. I just stayed overtime so that I could drive them to the appointment. And then you have this poor autistic person who is very upset, and you can't tell. But now we can see into the houses, we can see what they look like, we can see how they're acting. So that's very helpful to us, but it's helpful to get everybody's idea of what's going on. And we do take that into consideration. So we you know, as a mother of a child with a disability doesn't have epilepsy, but my husband's and my interpretation of what was going on at any time was often very different.
That's right. That's common. But we also use a lot the neurocognitive evaluation, the neurodevelopmental evaluation, and we need in the team. Necesitamos a alguien en el equipo que nos diga cómo está evolucionando el lenguaje, capacidad de comunicación, motricidad, etcétera. O sea que we need a team for this.
If we can get a team, which is often difficult.
That is true.
And it's more difficult now after COVID because more and more people, at least in the United States, are leaving the field. So it's harder.
De acuerdo, pues si no hay más preguntas. Any more questions? No. Vale. Pues muchas gracias, doctores.
Thank you very much.